We've had some uplifting panels. I think this one may be less uplifting because this is a very, very serious health challenge for the US and for the world. Every year in the US alone, some 2 million people are infected with bacteria that cannot be killed by antibiotics now, and we see thousands of Americans die every year from these resistant infections more around the world. They're the foundation of modern medicine. We may be in danger of losing antibiotics. And I actually, just to do a slight amount of self-promotion, I wrote a story that will be on the cover of Time magazine tomorrow on superbugs and pandemics. I actually got a chance to spend some time with Charles in San Francisco to talk about his work, and I think you can see that up now on the screen. But Jean, I want to ask you first, you as the CDC's science lead on this issue, can you talk about how we got here, how we got to the point where we're losing our most important drugs, we're losing the effectiveness of it, and really what that means for medicine?
Right. So antibiotic resistance is not new. It's been around ever since antibiotics have been discovered. But the way we used to deal with it is just to wait for the new antibiotic to come to market. And in fact, in a healthcare setting where most of these infections occur, an infection control strategy might be limited to using antibiotics to prevent an infection rather than implementing measures to prevent bacteria from moving from one patient to another. This resulted in a lot of antibiotic use, inappropriate antibiotic use. And in fact, we estimate that about 50% of antibiotic use in a healthcare setting is inappropriate or unnecessary. The same thing happened on the farm. So animals get infections just like humans do, and antibiotics help to treat those infections. And there's an added benefit for animals that the antibiotic use can actually increase the mass of an animal. This is great for food production, but it's not good for antimicrobial resistance. So this overuse of antibiotics, both for humans and animals, really drove resistance. Now we're seeing untreatable infections. A good example is a case that was reported recently by CDC, a woman who succumbed to an infection because her bacteria, the bacteria causing infection, was resistant to 26 antibiotics. There was no antibiotic available that could treat that infection. Now this is uncommon, but we can expect that these types of resistance will become more common. More often we see hard to treat infections, and those are bacteria that are resistant to multiple antibiotics, not all, but it really challenges the clinician in treating that infection and often results in more morbidity and mortality for the patient. It's really challenging modern medicine. I think the advances we're making in some diseases like cancer could be undone by antimicrobial resistance.
Charles, you're involved in the diagnosis side, and you do some really interesting work on next-generation genetic sequencing. You evolve into sort of diagnose infectious disease. Can you talk about that work and how it maybe can sort of influence this issue as we, because often we're broad prescribing, using antibiotics because we're not often sure what we're actually infected with. So, how does your work impact this?
Sure, absolutely. So next-generation sequencing, it's simply a fancy way of describing very deep sequencing or massively parallel sequencing. And it's really a technique that's revolutionized multiple fields, cancer, prenatal testing. And what we want to do is we want to bring it for infectious diseases. The general idea is what we do for our testing is we do metagenomic next-generation sequencing, meaning we simply take a clinical sample, we extract DNA or RNA, and we generate millions of sequences from that clinical sample. I view it as a needle in the haystack problem because what we're trying to do is we're trying to identify the very small fraction of sequences that may correspond to pathogens, whether they're bacteria, whether they're viruses, whether they're fungi or parasites. The goal is that you can implement a single sequencing test to potentially be able to diagnose all kinds of infections. And I think that part of what's driven, as Dr. Patel mentioned, part of what's driven really the development of antibiotic resistance has been really kind of the failure to make timely or adequate diagnoses. The fact is in the hospital, up to 50% of the time, we're unable to diagnose, for instance, neurological infections such as meningitis or encephalitis. Roughly a third of the time, we can't diagnose cases of pneumonia in intensive care unit patients. So really, the fact that we do not have adequate diagnostics that can capture the full spectrum of agents that cause disease is really sort of a clinical unmet need. Mm-hmm. And I feel that next-generation sequencing might be a way to address that.
Excellent. Jonathan, your work, your day job is actually involving stem cells but you have gotten interested in this subject. Can you talk, what about this, about antibiotic resistance sort of captured your attention, and how you're getting involved, I think, with some really interesting efforts to begin to figure out how do we get new drugs? We haven't had a new class of antibiotics since you told me, I think, 1987, right?
That's correct. About 2 years ago, in addition to, I run the $3 billion California Stem Cell Research Funding Agency, along with my colleague, Dr. Lloyd Minor. I can't see if you're out there, Lloyd. There you are, who spoke yesterday. I got very interested in this area, which has nothing to do with stem cells, but is a looming public global health disaster, and spent a fair bit of time sort of educating myself on what is being done with this. And there's been a lot of work producing some very interesting papers. The White House had a national action plan that came out last year, which you may know about. The Pew Charitable Trusts have had a roadmap to antibiotic discovery. The UK government commissioned an extensive look at this, which ended up with a white paper. So I sort of read up on all this, and there's been a lot of work identifying problems, but there is much work to be done in actually implementing a game plan that's going to really attack the issue. So towards that end, in conjunction with a couple of experts back in the Northeast last year, we pulled together a summit of the world's leading antibiotic basic researchers, and the idea was to lock ourselves in a room, approach a discussion with Manhattan Project like furor, and not leave the room until we developed a game plan as to what we saw as some of the most pressing issues in the antibiotic discovery space. And we settled on two, those two being the issue of permeation of gram-negative bacteria through the outer and inner membrane and efflux pumps. And the second issue was trying to reinvigorate the natural product discovery that was the cornerstone for antibiotic development in the 20th century, and basically has been dormant since then because of an inability to access more than 1% of the soil's antibiotic developing bacteria. So we came out of that summit with a game plan. I came up with, as I mentioned, a name I thought was sort of catchy. Everything needs an acronym. This was the Outer Membrane Efflux Gram-Negative Assault, or OMEGA. So it became known as the OMEGA Project, which I thought had a nice James Bond sort of ring to it, or perhaps Man from U.N.C.L.E. We have a commitment from all of these basic researchers who are there from all over the world to be a part of this effort, which would contemplate both a brick and mortar component where you'd have scientists working collaboratively in on-site together, and a virtual granting component, much like we do at our agency for funding stem cell research. And we would find the appropriate people to run it, and would sort of tackle the problem through that. And I think the plan we developed was a 5-year plan. It's about $50 million for the first couple of years, broken down into a budget. If anybody's interested, if we have any well-heeled philanthropists out there who are very concerned about this issue, would probably be $100 to $200 million over the 5 years of this OMEGA project. But we think if we're able to actually do something, and all of this is pre-competitive work that everybody could take advantage of as they pursue their own antibiotic development going forward.
Okay. Gene, is there, what's the policy answer to this? Because obviously we do need to develop and innovate new antibiotics, but do we also need to be treating the drugs that we have as a resource, essentially, that needs to be conserved? And if we do that, what does that mean in terms of how we use them for humans, how we use them for animals as well?
Right. So there's a huge effort to improve the way we use antimicrobials. And one of the keys is to actually measure how we use antimicrobials. We don't have a lot of data on that. One of the efforts that we're working on at CDC is surveillance for Antimicrobial Use that will capture electronic data from pharmacies and hospitals and allow a hospital to benchmark their use to use in similar hospitals. Similarly, we want to conduct surveillance in the same way, collecting electronic laboratory data from hospitals and being able to use those data for broad-based surveillance of new antimicrobial resistance. All of this is necessary in order to be able to prevent infections, develop strategic prevention measures, and to improve the way we use antibiotics.
Charles, you have sort of a study ongoing, I think, with the University of California hospitals. And just to talk a little bit about how this works, which is really interesting, because I mean, you told me, I remember, we don't know often as doctors, not that I'm a doctor, you don't often know, or other doctors don't know, what's causing meningitis, say, what's causing pneumonia, the actual agent. But you're actually going to be working with these hospitals to begin to figure that out by getting samples. So you sort of play that out a little bit. Sure.
So we have our own acronym for this. It's called PDAID. Stands for Precision Diagnosis of Acute Infectious Diseases. This is a nationwide study. It involves also several University of California hospitals, including UC Davis, UCLA, and UC San Francisco. The goal of the study is to enroll over 1 year, to enroll 300 patients, and to actually run this metagenomic next-generation sequencing test, what we call NMGS test, compare the performance of this test relative to all other microbial testing. So culture, antigen-based testing, PCR, multiplex PCR, serology, all of these are traditionally what we do in the clinical microbiology lab. These are diagnostic tests that we do to be able to identify causes of infectious disease. We want to actually compare the performance of this single sequencing test against all of these other tests. And part of the criteria, so this is a clinical test that's been validated specifically to diagnose neurological infections. So children and adults who have meningitis or encephalitis, these are probably the most challenging infections. About 50% of the time we don't get a diagnosis despite extensive testing. And one of the enrollment criteria is that patients must not have a diagnosis at the time of enrollment. And I can say that we have had actually quite a few kind of successful results from this. We were able to identify, for instance, the first case of flavivirus similar related to Zika virus called St. Louis encephalitis virus. This was a case in an elderly gentleman from Bakersfield, California, and he had actually acquired this from a mosquito bite. And it was simply because there are no clinical diagnostic tests that are readily available. There are some that are available at the CDC and at state public health labs. But the clinicians had not considered this as a diagnosis a priori. And it sort of highlights or underscores kind of the difficulty we face as infectious disease clinicians, because we want to basically formulate a differential diagnosis of what are the most likely causes of a patient's illness when they present to the hospital. And yet very often we may go through the list and we still can't diagnose the disease. So we want to kind of approach a targeted approach, and we want to place that with a more unbiased approach, where we simply can run a test and hopefully be able to reveal kind of the cause of the disease, in this case for this patient, which was actually the first case that was documented in California since 1986.
I'm going to open up to questions from the audience in a second, so just make yourself known to the microphone handlers. Jonathan, just real quick though, you mentioned the work Omega will be pre-commercial. How do we, eventually if drug companies need to get involved in this, how do we encourage them, or what barriers in the way to them investing more into developing new classes of antibiotics?
Well, that's been a major problem for decades. It sort of breaks down very simply. If you're a drug company and you have to put a certain amount of R&D funding into developing a new drug, would you rather do that for an antibiotic that might get used once every 3 years for 2 weeks, or into something that like a new Lipitor that will be taken daily for the rest of your life? Pretty simple decision. So the drug companies largely got out of this space starting back in the 80s, and as a result we've had a generation plus go by where you've had bacteria mutating to existing antibiotics and very little in the way of new development since. So the question is, how do you get them to engage? And I think there's been dialogue on this, particularly here in the US and in Europe. There have been a number of things suggested, none of which I think have been implemented, but some of the ideas would be, on the one hand, allocating existing resource. If you took 0.05% of the G20's annual total healthcare spending and allocated that to antibiotic discovery, that would give you $4 billion a year that could somehow be used as a subsidy for industry to get into this. Hasn't happened yet, but it's one idea. Second idea of reallocating existing resource would be if somebody gets into development, and it's a bit of a flyer here, if you're the researcher, if you actually come up with something, the government would pay you for service, or it would be a market entry reward, in effect, reimbursing you, and you could have that backed by some sort of international guarantee. On the other hand, there's creating new resources that could go into this, which could be any number of things. It could be a tax on antibiotic sales. It could be an investment charge to pharma, because antibiotics aren't only for infectious disease, but they're critical for many of the things that we take for granted, like joint replacement or organ transplants or cancer immunotherapy. If antibiotics become fully resistant, none of that stuff's going to work, and a lot of pharma's products that are going towards those different procedures will not work. So to charge pharma to come up with some source of revenue that would go into antibiotic resistance development. These are the sorts of things that are being bandied about, but so far there hasn't been any comprehensive solution, and until you hit that time, you're going to see pharma continue to be on the sidelines and the problem getting worse.
I think we have a question down here. Okay, go ahead.
Hi, Nahid Bedalia, Infectious Diseases, Boston University. I, first of all, want to thank you for doing the work that you're doing, because most mornings I wake up and I wonder if pandemic flu or antibiotic resistance is going to get us first, right? My two questions are, one, the issue is much more dire internationally. We have no idea, in places where antibiotics are just being dispensed with no regulation, how big the problem is, because there's no surveillance, laboratory surveillance there either. Jean, particularly for you, the question is there a commitment, you think, on a national level for regulatory involvement by countries to introduce that kind of, limitations in the future? And the second is, we think of universal flu vaccines as a potential measure for influenza. Is there a cross-category antimicrobial that you think might be in the works or something in the future that might work the same way for bacteria? Thank you.
Sure. So there has been a huge focus on an international response to antimicrobial resistance. And this is being led by the WHO and the UN. It's focused on building laboratory capacity to detect resistance. So just like for Ebola, where there is no laboratory capacity to detect these kind of infections and respond to them, the same thing occurs for antimicrobial resistance, and that's a key component. And then these laboratories will help to develop that surveillance data. So there's a WHO program to collect global data on antimicrobial resistance. And I just came from a meeting where we're asking countries to make commitments to this kind of surveillance activity. And it's growing, but it's growing slowly. This lab capacity is a huge issue. The issue of regulating antibiotics internationally is a hard one. That's going to probably move more slowly. There have been countries that have made steps to pass regulations to limit the use of antibiotics or the distribution of antibiotics. But there's a big difference between passing a law and enforcing the law, and we're really seeing that gap occur. So I think it's going to be a while. Once again, there's an effort to measure antibiotic use, and once you start measuring it, it starts improving.
We have one right there.
Can I just add to that?
Okay.
This issue of testing in different parts of the world. So there was a story last year of a pig that was detected in China that had acquired a gene through a plasmid transfer into an E. coli bacteria that the pig had that basically created resistance to any sort of antibiotic if there was a disease that arose from something that somebody would contract from this pig. And that there actually was a case that came up, I think, in Pennsylvania, was it? Last year, where this MCR1 gene that basically codes for full antibiotic resistance to everything showed up in a woman with a urinary tract infection. And this had a tremendously sobering and spooking effect on, because it was resistant to colistin, which is kind of the last line of defense. The Chinese had a surveillance program that actually detected this in the pig, which was very helpful, but there was a big concern, since colistin's fed to all their animals in agriculture over there, that there are lots of other things that might have picked up this plasmid that will ultimately end up getting transferred into humans. So unless there's tremendous vigilance internationally, you're going to have stuff like this cropping up. And we're not there yet to where this is dire, but as an FDA official said, it's not apocalyptic till it is.
You know, one of the challenges with that resistance is that, you know, we learned about it. In fact, the whole community learned about it through the peer-reviewed literature, which was several years after the gene had been discovered. So one of the things we're working on with WHO is creating a communication system so that we can learn about those types of critical new resistant events early.
Okay. We have time for just really very quickly one last one right there.
Hi, Lisa Boyette from Curable. My question for you is, thank you for all of the work that you're doing, and clearly it's all badly needed. But scientists have been clamoring from within and without outside the government since the 70s for slowing the development of resistance in industrial agriculture. And without real effort there, are we just going to be fighting this battle over and over again? It's so easy to get antibiotics in that domain, even though it's not for human use.
Jean, do you want to take that very quickly?
Sure. So you're absolutely right. Unless we can you know, improve antibiotic use on the farm, then we're going to continue to see these new problems arise. I think, you know, there's a new era of political will to address this problem. I think that's going to go a long way. But actually in the US, it's consumers that are really driving that change. I mean, I think you heard from Tyson at this meeting that they're going to raise antibiotic-free animals, and that's just a huge change. And it's really consumers driving that change.
Well, thank you very much to the panel for this subject, and thank you all.